Hello and welcome. I'm Fernando, a GP in the UK. Today we're doing a review of the NICE guideline on CKD or NG203, focusing on what is relevant in primary care only. Given how extensive the guidance is, in this episode I will just focus on other CKD management in primary care, including the management of renal anemia and CKD mineral bone disease. If you haven't already, I recommend checking out the 2 previous episodes on diagnosis, classification, monitoring, referral recommendations, and blood pressure management in CKD. Right, let's jump into it. And let's remember that for this review, I have excluded recommendations related to children and young people with CKD. SGLT2 inhibitors have been proven to help CKD in both people with and without diabetes. There is NICE guidance on dapagliflozin and empagliflozin, but their use is outside the scope of this episode. Links to this guidance are in the episode description. The advice on statins in CKD is also covered in a different NICE guideline. The link is also in the episode description. But in summary, in CKD, we will give atorvastatin 20 mg for both the primary and secondary prevention of cardiovascular disease. Then, if the lipid target is not met and the eGFR is 30 or more, we will increase the dose. However, if eGFR is less than 30, we will discuss and agree the use of higher doses with a renal specialist. We will offer antiplatelet medicines only for the secondary prevention of cardiovascular disease, being aware of the increased risk of bleeding in CKD. And why is this? The real cause for the association between CKD and bleeding is not well known, but research studies have shown that CKD has been associated with a 1.5-fold increased risk of bleeding, which has been attributed to platelet dysfunction and activation of the fibrinolytic system. However, although some patients are prone to bleeding, other patients also develop excessive clot formation. Little is known about the reasons why some patients develop bleeding while others have excessive clotting. So, in summary, for the secondary prevention of cardiovascular disease, we will definitely need to give aspirin, but being aware of the risks. We know that renal anemia can be common. Do we need to fully investigate everyone with CKD for this? NICE says that we should investigate and treat anemia in CKD if the hemoglobin is 110 or less, or they develop symptoms like tiredness, shortness of breath, etc. Then, if eGFR is above 60, we will fully investigate other causes because it is unlikely to be due to CKD. If eGFR is between 30 and 60, we will investigate other causes, but we will use clinical judgment to decide how extensive this investigation should be, because the anemia may be caused by CKD. And if eGFR is below 30, we will think about other causes, but we will note that anemia is often caused by CKD in these circumstances. Why is this? Let's have a look at the causes. Anemia of CKD is generally a normocytic, normochromic, hyperproliferative anemia. Although the widely accepted cause is a decreased renal production of erythropoietin, the hormone responsible for stimulating red cell production, anemia of CKD is of multifactorial origin. Other mechanisms include uremia, folate and vitamin B12 deficiency, iron deficiency, a shortened lifespan of red blood cells, and bleeding due to dysfunctional platelets. And very significantly, CKD patients are at higher risk of iron deficiency, so we must always consider iron supplementation as part of their treatment. Consequently, as we have just said, the management of anemia in CKD involves iron therapy, erythropoietin stimulating agents, and blood transfusions. Let's begin with iron therapy. In primary care, we should check for iron deficiency at least every 3 months, and we will diagnose iron deficiency if the percentage of hyperchromic red blood cells is more than 6%, the reticulocyte hemoglobin content is less than 29 picograms, or transferrin saturation is less than 20%, and ferritin is less than 100. However, these last two tests alone are not ideal for assessing iron status in CKD. They should only be used when other diagnostic tests are unavailable or when the patient has conditions like thalassemia or thalassemia trait. When treating with iron, NICE says that ferritin levels should not exceed 800, and to prevent this, we will review the iron dose when ferritin reaches 500. So what this means is that we are going to keep giving iron to our patients even when their ferritin is well above the normal range. Why? This is because in addition to true iron deficiency, CKD patients also have a functional iron deficiency, which is a type of cell iron blockade. This results in reduced iron release from body stores, which is then unable to meet the requirement for erythropoiesis. By having a higher than normal ferritin, we would expect iron to be released for erythropoiesis more easily. Erythropoietin-stimulating agents and blood transfusions will be guided by secondary care, and I will not cover it here, except to say that we should avoid transfusions in patients who are candidates for a kidney transplant. This is because multiple transfusions increase the risk of developing HLA antibodies, which can reduce long-term graft survival. Other aspects of CKD management include hyperphosphatemia and renal acidosis, which will normally be managed in secondary care. So the use of phosphate binders or bicarbonate will not be covered here. However, NICE does talk about the effect of CKD on bone metabolism and osteoporosis. What is CKD mineral bone disease? It is the disturbed mineral metabolism caused by uremic toxins and secondary hyperparathyroidism, which disturbs bone mineralization and makes it difficult for calcium and phosphate to enter the bones. This can result in higher serum calcium and phosphate, as well as in bone loss. The prevalence of osteoporosis in the population with CKD certainly exceeds the prevalence in the general population. As already mentioned, when bone resorption exceeds bone formation, calcium and phosphate are released into the bloodstream, and they contribute to hyperphosphatemia and hypercalcemia. This is an important stimulus to what is called heterotopic calcifications, especially in blood vessels, which can lead to cardiovascular events and mortality. Consequently, vascular calcification and osteoporosis are the most common complications related to CKD mineral bone disease. And because vitamin D deficiency plays an important role in this, vitamin D supplements are important in treating both osteoporosis and vascular calcifications at the same time. Although NICE says that vitamin D should not be prescribed routinely, proven vitamin D deficiency should be treated with cholecalciferol or ergocalciferol. Then, if vitamin D deficiency is corrected, but symptoms of CKD mineral and bone disorders persist, this may indicate a need for treatment with alpha-calcidol or calcitriol. And let's take a moment here to understand why. For this, let's give a quick overview of vitamin D metabolism in the human body. The proximal tubular cells in the kidney converts vitamin D into the active form calcitriol, also known as 1,25-dihydrocholecalciferol. As kidney disease worsens, there is a reduction in the renal 1-alpha hydroxylase activity for converting vitamin D into the active form calcitriol. So why do we bother with cholecalciferol or ergocalciferol? Well, whilst you would think that giving calcitriol straight away would be the solution, we also know that treatment with cholecalciferol or ergocalciferol has been shown to increase calcitriol levels in both stage 3 and stage 4 CKD. So this is the reason why cholecalciferol and ergocalciferol are the first-line approach, and treatment with alpha-calcidol or calcitriol remains second-line. So that is it, a review of other CKD management in primary care, including the management of renal anemia and CKD mineral bone disease. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.